it is such an exciting space in cholangiocarcinoma in terms of drug development and focusing on novel therapeutics for these patients. It's hard to even summarize. I mean, obviously, anybody that treats the disease as well as the patients wants immunotherapy to work in cholangiocarcinoma. And initial studies have been disappointing in terms of single agent checkpoint inhibition with the keynote data that came out with pembrolizumab, for instance. But this year at ASCO, for instance, we're seeing signals that are suggesting that immunotherapy does have a role. There's the data out of Korea that is, again, looking at checkpoint inhibition. Granted, we know that that's a primarily Asian patient population, and that is probably biologically a somewhat different population than, say, the patients that we treat in the United States. There was the data looking at nivolumab and ipilimumab, for instance. And while that data was a little disappointing out of University of Michigan, again, it does suggest that we can and should be thinking about immunotherapy. The single agent data with nivolumab out of Moffitt also, which was published recently, definitely piques everyone's curiosity and raises eyebrows because it's a higher response rate than we had seen, for instance, in other single agent checkpoint studies. That being said, that was on investigator-assessed response as opposed to centrally reviewed radiographic response. But the point is I think that there, is a lot of excitement and enthusiasm to figure out how to make an immunotherapy work. And I think all eyes are on the frontline studies. So, there's a gemcitabine and cisplatin with nivolumab, there's a gemcitabine cisplatin with pembrolizumab, durvalumab. So there's a lot of interest. We're keenly awaiting that data to see if perhaps there is a synergy when you use cytotoxic chemotherapy with checkpoint inhibitors, since we're not 100% sure that checkpoint inhibitors alone can work. In terms of other kind of areas of interest, I think, of course, as we use targeted therapies, we are seeing resistance emerge. And so trying to understand how to approach FGFR2 resistance, for instance, given that we have so many drugs available, can we treat these patients sequentially? Are there mutations that we can follow on ctDNA, for instance, that can help guide that therapy? That's an area of great interest to us as we're treating these patients in the clinic and as these drugs become available. And the infigratinib study that's ongoing right now for patients who have already received prior FGFR therapy is a really important piece to that puzzle. And then, of course, I am a firm believer that cytotoxic chemotherapy is down but not out, if you want to call it that. And my hope is that we can build on gemcitabine and cisplatin in the frontline setting or FOLFOX in the second line setting. And so there's a lot of frontline studies right now that are looking at, say, nucleoside analogs, like the NUCANA study, which is the nucleoside analog similar to gemcitabine with cisplatin. There's, of course, SWOG 1815, which is a randomized study that I, of course, am very interested in seeing the results of, since I'm the national PI, but it's gemcitabine and cisplatin versus gemcitabine, cisplatin, and nab-paclitaxel. So a triplet chemotherapy regimen to see if we can augment response and survival in newly diagnosed patients. So I think there's a lot of work going on in a lot of different spaces, and I don't doubt that we're going to have more drugs for our patients soon. My advice to community oncologists when it comes to using targeted therapy in cholangiocarcinoma is, number one, there's a role. So I think educating everyone, not just community oncologists, but everyone, about the role that targeted therapy can and should be playing in cholangiocarcinoma is really important. And so number one is the importance of doing molecular profiling with next generation sequencing on patients, and doing that efficiently and right at the time of diagnosis so that you can integrate what you learn from those reports into your algorithm for treating these patients. The other advice I would say is that back when I first started treating this disease, it was, slim pickings in terms of clinical trials being available for our patients. And now there are so many trials out there. And, if a community oncologist doesn't have a great idea after GemCis, or even doesn't have a great idea in a newly diagnosed patient, please refer them to an academic tertiary cancer center that has a robust clinical trial portfolio, because we are absolutely moving the needle forward on these patients, and we're doing trials. And so my advice would be to collaborate with the experts in the field and really help us continue to make progress.